Good morning or afternoon. I'm Nikki Boyd with Sachs Healthcare, and I will be your technical producer for today's webinar. Before we get started, I'd like to review a few housekeeping details. Today's webinar is being recorded. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. Our speakers will try to answer as many questions at the end of the presentation as time allows. If you experience technical difficulties, please use the Tech Support tab also located on the right-hand side of your screen. If you have trouble seeing the slides at any time during the presentation, please first press F5 to refresh if you are on a PC or Command-R if you are using a Mac. Make sure you are not behind a firewall, as this will prevent you from viewing the presentation. I would like to introduce our moderator, Lexi Caraway. Lexi Caraway is currently a senior patient trainer for Hillrom and a member of the Illinois Society for Respiratory Care Board of Directors, currently serving as a delegate and also as Illinois PACT co-chair. Lexi has published several abstracts for the AARC Open Forum, including a study titled Telemedicine: Improving Quality Metrics in a Rural Community Hospital. She is presented at several local and state respiratory care conferences. As a final reminder, there is a handout located below the webinar slide player on your screen, and you can click that for download. Thank you, Lexi. Welcome.
Good morning. Thank you, Nikki, for that very kind introduction. The title of today's webinar is Breathe Easy, RN and RT Coordination of Care. We are excited to have two clinicians who are dedicated to improving coordination between nurses and respiratory therapists, Bridget Joseph and Nina Koyama. Dr. Joseph is the CEO of Thrive N LLC, a healthcare consulting company. She is a certified clinical nurse specialist in critical care. For over 12 years, she worked at Beth Israel Deaconess Medical Center in Boston, Massachusetts. At the BIDMC, among her leadership positions, she was co-chair of the Resuscitation Committee and the Director of Simulation Education with a specialty in interprofessional education. She was also Director of Patient Experience at Yale New Haven Health, L&M Healthcare. Dr. Joseph has worked on clinical research both here in the U.S. and in the U.K. She speaks at many healthcare conferences throughout the U.S. Nina is currently the Respiratory Care Coordinator, NICU, at the Beth Israel Medical Center in Boston. She is responsible for representing the NICU respiratory care team for the medical center, participates in quality assurance practices, clinical education and mentoring of staff, and also coordinates staff training and provides care to patients and families. She is a certified instructor for neonatal resuscitation program and BLS. Nina is currently participating in 2 research projects relating to surfactant protein D. Bridget Joseph has disclosed that she is a consultant for Stryker Medical and Nuarva, and Nina has no disclosures. This educational activity is approved for 1 contract hour for nurses and respiratory therapists. A link to obtain credit will be available at the end of the webinar. Support for this educational activity has been provided by Philips. At this time, I would like to turn the presentation over to our first speaker, Dr. Joseph.
Thank you, Lexi, so much for the lovely introduction. And thank you all for hopping on and listening to Nina and I talk for the next 45 minutes or hour about the RN and RT coordination of care. So we all know that respiratory therapists and registered nurses do overlap in some of the care that they give patients. And we want to look at what we can do to emphasize that and really improve patient outcomes and patient care. So our objectives today are to identify the ideal state framework for collaborative care of respiratory therapists and registered nurses, define procedure-based treatment care that's supported by both RNs and RTs, and then outline a future state med-surg coordination of care. So we're going to start and talk about a framework for practice, and really that starts in the ICU. That's where we have it kind of nailed down, and that's where we're going to start our journey here today. So I'm actually going to toss it over to Nina, and throughout the presentation, you're going to hear Nina and I talk back and forth to each other, and it's all for your benefit, I promise. But I'm going to hand it over to Nina so she can start talking about that framework in the ICU.
Well, great. Thank you, Lexi, for that introduction, and thank you, Bridget, for inviting me to collaborate on this project. I've been a respiratory therapist for over 30 years, and I've been fortunate enough to, right from the beginning, to work with some amazing nurses, and they really took me under their wing to make me a more well-rounded clinician. I've learned so much, and I'm enjoying paying them back now by taking some time to support and educate many of the newer nursing staff that started in our ICU. So really, we're going to first focus on the framework for collaborative care in the ICU. And it's really important to spend some time on focusing in on the mastery of teamwork. A major contributor to a well-functioning ICU is great teamwork driven by high-performance teams. So what is teamwork? Teamwork is two or more individuals with specific roles and tasks who share a common goal and perform tasks that are interdependent. An example of this could simply be somebody holding a ladder for someone else so it doesn't tip over so they can change a light bulb. But this simple but interdependent task, if we take it into and perform it into an ICU, has been recognized as a very important factor in preventing medical errors and improving patient safety. When we continue to work together in this fashion, eventually we can create high-performing teams. High-performance teams communicate effectively, they provide regular feedback, they understand each other's roles, they anticipate each other's needs and behaviors, and they're able to manage conflicts and support each other at this time. Another example would be, I live in New England area, and for many years, I've been able to witness high performance teams firsthand. And that was in the era of Tom Brady and the Patriots. You know, in a very short amount of time, they've been able to go around and collect 6 Super Bowl titles. Well, when Tom left for Tampa, you know, we were all upset, but he actually recruited some key players to join him. So what he did was he actually brought together his high performance team and was able to replicate his teamwork for another Super Bowl win. Well, in the ICU, we see this every day, especially when a crisis happens. Our teams coordinate and collaborate together at such a high level that in any response to these situations that are worthy of a Super Bowl ring. We also see this in our code and rapid response teams. Each person has a specific role, but they work very interdependently to save lives. And this is what we want to accomplish with every team we create in the ICU. So communication is another thing that we want to look at. It plays a key role in the mastery of teamwork. Below, I've outlined 3 structures of communications we use in the ICU. The first is the team meeting. So the team meeting is really a brief, scheduled gathering of all the team members to share information such as patient acuity, expected procedures, transfers, potential discharges, and this is usually done at the beginning of each shift. The second is updates and huddles. These are spontaneous brief team meetings in anticipations of future events, or it could be held to increase some awareness of an acute situation going on to determine the appropriateness of a response. Know that any person can initiate an update if they recognize an acute situation that might require one. The third is the debriefing. A debriefing is a spontaneous meeting of a small group of people in response to a past event. During this meeting, members identify strengths and weaknesses of team's performances during a prior event. They look at what went well and what they really need to do to improve upon the situation. Team meetings and updates, they help identify members of the teams who might require some extra assistance. And then while debriefings help provide support after difficult situations, a debriefing allows everyone to regroup, to take a step back, to take a deep breath, to support each other. You know, in many cases, it's not only a time for high fives like, hey, this went really well, but it's also a time to recognize and give support to those members who were challenged by it. And it's also a time to make a note to where more education is needed. This is where we identify ways to improve our high performance team. Another component of mastering teamwork is situational monitoring. It works very closely with situational awareness and a shared mental model in almost a continuous loop of assessing and implementing and looking at it again. So with situational monitoring, it's really maintaining a local and global awareness. It's keeping a bird's eye view of a patient or of a situation or of the unit. It is actively assessing and reassessing a situation to gain or maintain accurate awareness of the environment. An example, real examples of this are our team meetings and our updates, which I'll go through, give examples of in a little bit. Situational awareness is having a detailed picture of the environment, kind of identifying issues that are there. This also can be a local or a global awareness. And then we have shared mental model. This is when all providers have the same understanding of a situation and they're really digging deeper into finding out what's going on. It allows the team to work towards the same goal. The benefit of a shared mental model is it provides common understanding of a patient's condition and plan. It facilitates collaboration, decision-making, and it provides basic predictive behavior and needs for the team. And a shared mental model. Oh, sure.
Sorry, I was just going to butt in for 1 second. The one other thing that, you know, a shared mental model can help with the situational monitoring is just having that, you know, monitoring, just like anything else, monitoring someone's oxygen saturation, their blood pressure, it's going to go up and down, it's going to change. And you're just looking to see, you know, that ebb and flow, just as you are when you're monitoring a situation of a unit or a particular patient or, you know, hospitals in general. And so having that shared mental model can help so that you can, just like you were saying, you really can predict, you can start to see where these patients might go, and how we can work together and how we can utilize our resources better, which is why in the ICU, it's a lot easier to do this because you're working together side by side.
Yes, and it does. It's amazing how closely the relationship is between the nurse and the therapist in the ICU. And that really, that shared mental model, it has shown that it does help teams avoid errors and really keeps patients at less risk. So here's an example of a situational awareness or situational monitoring. It's holding a team meeting. So a team meeting in the ICU can go something like this. It's really a time when the team shares a brief information about both the state of the unit, what are we expecting, and or what's going on, and then also the state of the patients in the unit. So the nurse identifies their patients and gives a brief description of the current status. So, for example, it might go as nurse number one might say, "Hey, I have Mr. Jones today, and he's stable." Nurse number two might say, "Hey, I have Mr. Smith, and he's pretty critical, and he's actually on dopamine and has other things going on with him." Nurse three, "I have Miss Parker, and she's going to be transferred and moved to the floor today." Or nurse number four might say, "I have Mr. Chan, and he's being discharged today, but you know what? I've never taken care of this patient before." So they would continue to go around to each nurse and make sure that everybody understands what their patient load is. And then the therapist may take that time after that and address specific concerns about a patient, or maybe state the restrictions they have in availability, like, "You know what? I'm covering the unit today, but we had a sick call and I might have to step out of the unit for a while. I'm just letting you know because I might have to help out in other units." So what happens once everyone presents? A nurse might respond, "Hey, I've taken care of Mr. Chan. I will help you with that discharge this afternoon." Or the respiratory therapist might schedule a time when she can coordinate care with the nurse taking care of Mr. Smith, that really critical patient that's on dopamine. So these are ways that the team meeting really gives us a bird's eye view of what's going on in the unit and ways that we can balance things out. I don't know if Bridget had anything to add to that at all.
No, I just think that, well, I always have things to add. You know me. But I do just think that this is a great time, and these are great examples of exactly how it goes in the unit and in the ICU. And I think Nina and I forgot to tell people that we've worked together for quite a few years, and I was an adult ICU nurse. But so we never actually worked on the units together. However, we've worked together otherwise for many years. So that is exactly how it goes, at least, within the various ICUs that I've worked in for adults. And when we were talking about this, and I was like, oh, works the exact same with little babies. So whether you're big, small, whatever, in the ICU, when you have 1 to 2 respiratory therapists that are working with the nurses, having this meeting of the minds and having the ability for the respiratory therapist to have maybe a little bit of insight that goes beyond respiratory therapy and into the nursing world, and same with the nurses, having that overlap is really crucial, because exactly like nurse number 4, when she has Mr. Chan who's being discharged, she's like, I don't know him from a hole in the wall, and that happens, and you have to discharge someone that you don't really know what outside of reading notes and whatever, you don't know the intricacies and this the special little nuances of that patient, but maybe a respiratory therapist does, that's been taking care of them, so they can kind of be like, oh no, this is how we've been doing it, because this is how he likes it, or his family likes it, or blah blah blah. And it's really helpful to have that going together, working together, and to be able to have that conversation of coordinating care when we can do something on a critically ill patient, and when we can work together to really optimize our time and optimize our care with that patient, and to be able to communicate with the families and the other healthcare providers to let them know, we can't have a test now. This is when we're doing X, Y, Z. And it's just really, this is when our communication and our teamwork is just truly optimal.
Great. Thank you, Bridget. So I'm just going to move on to another component of mastering teamwork is in the ICU is coordination of care. The nurse and the respiratory, it might be the nurse and the respiratory therapist communicating to schedule care times. When they arrive at the patient's bedside, together they can assess the respiratory status of the patient. The respiratory therapist can then assist the nurse with optimizing patient comfort. It might be securing or adjusting their breathing apparatus. It might be providing the breathing treatment for that patient, or really making the patient comfortable with repositioning, because 4 hands together are better than the 2 by themselves. So working really close together with the nurse to make sure there's optimal comfort for that patient. They can also share insight, into the respiratory assessment of the patient, and the treatment of the patient. What are we going to do for that patient today, and what are the goals that we want to achieve for that patient? They can also support each other by bringing up concerns when they observe something that has changed in the patient's status. And really, by doing so and consulting each other, they might be able to minimize a patient crisis. So I'm just going to give you an example of coordination of care in the ICU. So the nurse and the respiratory therapist come together to assess a patient. And the nurse notices that the patient's work of breathing has increased since the last time she did care times on the patient. So the therapist grabs a stethoscope and begins listening to the patient's lungs and notes that the left side lung sounds are diminished. And the nurse takes a listen to them also and agrees upon that. So then the nurse goes and she shares concerns with the rest of the team by calling a huddle at the patient's bedside. And the team assesses and they discuss a plan for this patient. So they get a chest x-ray on this patient, and it does confirm that what we're hearing, and that this patient has a pneumothorax on the left-hand side. And then maybe that the team is able to come and intervene with that patient, evacuate that air maybe, or put a chest tube in, and that really minimizes the patient crisis, which could have, if gone unfound, could have led into something much worse. So you can see in this example that I described that we have situational awareness. We have the nurse and the respiratory therapist kind of identifying, hey, this patient is in distress. And then they have this shared mental model together that the team comes together and they start setting upon an action plan for this patient. And then situational monitoring really follows up by this continuous loop of looking back and keeping a close eye on this patient and hopefully avoiding any further crisis.
And I just think that one important thing that that you did touch on, Nina, is that, the nurse is like, hey, can you come here and listen to the lung sounds too? Can you auscultate and see what you hear? Because I know that I worked permanent nights for 10 years, right? And I was getting my master's during that time. So by day, a student, by night, working in the ICU. And there were times that I was exhausted and I was like, and I started to not trust myself or what I was hearing. And it was so crucial to really have that relationship with either another nurse, but especially another respiratory therapist to be like, that doesn't sound the way it did, does it? And to have that, expert there right at the bedside with me, especially with lung sounds where things can change and change pretty quickly in a critical care patient. So I love this example because it really does pull together everything that we're looking to do when coordinating care.
Yeah, and I work in a neonatal unit, but we work so closely with nursing, and we're the first ones they grab if there's an issue with a patient. It's not the physician or the nurse practitioner, really. It's the respiratory therapist, because it's usually the babies in respiratory distress is usually the first issue, and so we do have a really close relationship with nursing and respiratory. Well, I hope this kind of gave you a general, go ahead, Bridget.
No, I was going to say, so that's how that's the ICU collaboration, but then, the big the big burning question here is, can you do that outside of the ICU, where a nurse and a respiratory therapist, or nurses and respiratory therapists, aren't necessarily working side by side together? But how can we do that we're sharing our, our expertise together? So I think Nina did a great job of opening up kind of our introduction and where we're gonna try and get today with our talk, and hopefully we can land the plane soon. But I want to talk about, there are so many different just procedure-based treatments that we do, that respiratory therapists do, that nurses can do. And sometimes we overlap with this care. Sometimes we're, doing it together. Sometimes we're not. But the beauty of the respiratory therapist is that their focus is specifically on these treatments with these patients. And they can really support the nurses when we're ensuring effectiveness, or if it's a titration of O2, with support for education with our patients in the med-surg area that, may have questions about why we're doing what we're doing. And quite frankly, some of the treatments that we do with patients don't necessarily feel good, but it is getting them on that road to recovery. So I want to talk a little bit about these procedure-based treatments that we can kind of, oops, and I'm not switching my slide, that we can collaborate, work together on, and really support our patients. So I want to talk about BiPAP and CPAP, because I feel like, first of all, when I worked in med-surg, it was extremely confusing to me, the difference between the two. I'll be honest with you. I knew that there was a difference. I didn't really know the difference, but I knew that it was a big deal if you had to put someone on BiPAP, because then they weren't in the on the med-surg area anymore, and that was kind of where I left it. But I was also, working in solid organ transplant, so if you don't know the difference, do not, you're not alone there. So BiPAP is bi-level pressure. That they're giving. And both of these treatments, so CPAP and BiPAP, do have continuous pressures to help and support open airways for patients. But BiPAP has a different amount of pressure during inspiration and expiration. So BiPAP, because it's two pressures. And so BiPAP is more used in the hospital setting, whereas CPAP is something that is used at home. It's used in the field by EMS, and mostly because it's one continuous pressure. It does help to keep that airway open. It's something that you can do and place on a patient quickly, and see if you're going to get a response. It doesn't have all that much monitoring. And Nina, you can jump in and correct me if I'm speaking out of school on any of these things. But BiPAP does need a little bit more monitoring for patients. They can, like when we're first starting it, they can, have changes in their blood pressure or heart rate. It can be very uncomfortable for them. And we want to make sure when you start a treatment like this, or you're maintaining a treatment like this, you want to make sure that you're doing it for the right reason, and that we're actually benefiting the patient, right? So sometimes, if things are, you set it and forget it and it's looking good, and you're thinking as a nurse, like, great, their oxygen sat's fine, the respiratory rate's like, it is what it is. Great, looking good. This patient is solid on their CPAP. But then you may have that patient that has a constant air leak with their mask. So I know that there are sometimes that, you feel like you just can't get the right mask fit. Well, and then you have the superhero respiratory therapist that comes in with like, oh, you can try this mask or this mask or this mask. And as a nurse, I didn't realize we had all these different options for masks. I thought it was, big or small, and that's it. You got a big face, you get a little face. But there are different masks that you can try. You can do the over in the nose, you can do over the mouth, you can do different ways to get it to move their head or to position their body to help and support, a decrease in air leaks. Because sometimes it's, it can be that facial structure of a patient that it's just like flubbing in the as the air is going in, and that's not helping anyone. We know that's not effectively oxygenating anyone, and their vitals will reflect that. So that's like an help, SOS, RT, please help us refit this mask. Do we just change pressures? What do we do here? And I've had that many a times that, I've tried every trick that I have in my bag. And then I'm like, this is not working. So working with the respiratory therapist on those patients can really get you to that optimization of treatment goals, notice any signs of concerns. And obviously we're going to know if their vital signs are tanking or if their, respiratory status is significantly changing. But we want to just make sure that, that we're doing the best that we can, and respiratory therapy, there at the bedside can really help significantly. So then we move to the heated humidifiers. So what are those patient populations that we should really be using heated humidifiers on? In the ICU when they're have an endotracheal tube, so they're already intubated, it's a little bit easier to make that decision. If it's chunky in there, great, we might heat it, humidify it, just get a little more oxygen into those lungs. But how do we set it up? How do we assess it? And to be honest with you, this is usually, in my experience as a critical care nurse, this is all respiratory therapy. I mean, it'll be on, and if it's beeping, I know to look at it and say, and then call respiratory. I don't know why it's beeping. Maybe it's out of, sterile water. Maybe it's, there's a kink in the line. And sometimes that happens. I would know when it got filled up in the tubing and you would just empty it back out. But who are those patients that we should be thinking about using it on? And, there are some of those pneumonia patients. There are some of those, the early COVID patients that would have really, and I know we were trying to limit AGPs, but really those patients with a really chunky cough, like there's stuff in there that they can't get out and they need help getting out, that we're going to want to humidify it to help loosen it up so they can cough it up like an expectorant. Nina, do you agree or disagree on that one?
No, I agree. Yeah. So yeah, really identifying those patients that really need to actually loosen things up and make them a little bit more comfortable.
And then we have high flow therapy devices. So, and those became really, I know that they've been around in hospice for quite a while. And so I know that at least for in hospital and in our hospital, I know that at some community hospitals they've been used and in hospice areas, but in larger medical centers, they were not something that was used with super, I would say, regularity until COVID came. And then when COVID hit a lot of hospitals, then it became, okay, so can we put these patients that may be struggling a little bit more with respiratory issues on high flow O2 and get them on the med surg floors? Is this safe? Can we do it? Because we were trying to make ICU beds at that time. And I think every hospital that was hit with those first few surges, like the February, March, April of 2020, we were all kind of overwhelmed with ICUs just being flat out. And what are we going to do and how are we going to make room? So we brought in these high flow O2 devices. But this was a place that we really needed education from our respiratory therapists, and we needed to work really tightly on, what are the appropriate patients? These patients are seemingly easy to care for, but we know that they're on really high oxygen. So we know that they can also flip really quickly and get really sick. So they're more, tenuous, at risk for a fast decompensation, much faster than a patient on a regular nasal cannula, right? It's not the same as, just ramping up the nasal cannula and then putting on a high flow O2 if that's the case. But we needed to work a lot with the respiratory therapist so they could help and figure out which patients were indicated for this. What were the risks? What should we look for? Were there any different clinical assessments that we should look for signs of distress? And we knew that there's an extra little reservoir. So anytime patients needed some extra, oxygen, if they just gave an extra sniff, they get a big bolus of oxygen. And that was a lot of education for the med surg nurses, because we didn't register that. We didn't recognize that because that was, something we hadn't used. And the same with the oxygen concentrators. Same thing. It gave an extra, essentially a bolus of oxygen to these patients that were, seemingly okay with a new virus process that we were not totally sure of, the trajectory. And it was looking for those signs of distress, when we should use them, when we should, maintain a patient in the ICU on it, when we could, move them into like a PACU surge area. And so working with respiratory therapy was really crucial with that, so that we could look for those signs of distress, and so that the med-surg nurses could understand a little bit more about, when to use these. And then obviously ventilators. And I know that some, I would say a majority of med-surg areas do not use ventilators as a blanket statement. However, there are some patients that are on same settings, ventilators, they are trached. There's really no change in their respiratory status, and they will be left and sent to a med-surg floor on a ventilator. And we've had numerous occasions that we had to look at that and train the med-surg nurses on what to look for, how to use it, what are some of the clinical changes, like if we're changing PEEP, that the patient's blood pressure might change, or heart rates, or we're not going to change anything, but what to look for in a patient that's on a chronic vent. Because some patients do go home on vents and they have it, but we do need that support from respiratory therapists of like, how to suction, should I be lavaging? There are those things that you take for granted when you're in the ICU, because that's, a commonplace skill. But I remember when I was on med-surg and my first time shadowing in the ICU, I was like, holy moly, the ventilator just threw me for a loop. It was beeping and the person was bucking, and I was like, oh, I don't know if I can do this. But I did. But it's one of those things that on a med-surg nurse, you really need that collaboration with the respiratory therapist that does that all the time. So I want to talk to you guys a little bit about a clinical case, so we can kind of pull this all together, right? So we have the collaboration that we would ideally like, and now we know the various items that we would, be working with, with a respiratory therapist. So there is a patient that arrives to the ED, a 66-year-old female. She's in no apparent distress. And her initial assessment and triage is that she's normothermic, self-screens out for COVID. She does complain of shortness of breath and cough, so one might think that might screen her in, but she says no. She does have some chest pain after exertion. So walking from her car, for example, to triage, she did have a little bit of chest pain, but then she sat down, and while she was waiting, it resolved, no problem. She was having some increasing sputum with her cough, a little bit of increasing fatigue, so she decided to pop on into the ED and see what we had. And her big history is that she is a 1 pack per day smoker for 37 years. Yikes. And usually she has like a daily cough. She wakes up every morning, cough, cough, cough. And then she has some white sputum. Then she has her first cigarette. It goes away. It's fine. And then she's had similar episodes in the past during cold weather, but she never had the chest pain. So that's the one thing that really freaked her out. So her vitals, as she was admitted to the floor, are that, or I should say, in the ED, her blood pressure is 119 over 77. Her heart rate was 92. Respiratory rate was 24. And someone actually counted. They didn't just write that down. And then her sat was about 95% on room air. So by the time she was getting admitted to the floor, and what kind of made her hit criteria is that she had some increasing oxygenation needs, right? So her blood pressure did go to 98 over 51. Her heart rate was 109. Respiratory rate kind of shot up to 28, which is pretty high. And then her O2 sat was 92% at that point on 2 liters of nasal cannula. Nina, what are you thinking? She's healthy as a horse?
Oh, she's in trouble. She's in trouble.
It's almost as if you knew it. So shockingly, our little friend, her respiratory status starts to decline. And so what's happening is that she starts, they notice on the floor that she's having a little bit of cyanosis around her lips, nothing like crazy, not like blue lips. But when they look at her, they're like, that looks a little bit bluer than it was. Her O2 sats are dropping. And the new nurse, the less seasoned nurse, would just like, what, I'm going to give her a little more oxygen and let's just see what happens. Let's watch. And then the more seasoned nurse, might temporarily increase the oxygenation just because her sats are dropping a little bit, but immediately page respiratory therapy. So as they have that hand on that dial turning it up, they're also hand on the phone or however you page in your institution, getting respiratory therapy to the bedside. So when respiratory therapy comes to kind of assess the vital signs, look at the patient, just ensure that we're not, putting the oxygen, the O2 too high, which can happen. With certain patient populations, you don't want to give them too much oxygenation. So they start doing, a physical exam and looking specifically for, that paradoxical rib movement, any distant heart sounds, accessory muscle movement, and then just the all over picture of this woman's lung sounds, right? She does admit that she's been a smoker for 37 years, or a pack per day for 37 years. And, she's had this chronic cough for God only knows how long. However, it is obviously getting worse, and she's having that chest pain, but it's resolving, so we don't necessarily think it's cardiac. So then we kind of want to look together, and sorry, that is teeny tiny type, so hopefully you guys can see it, and I know you guys have a printout, but so some of the commonalities that the nurse and the respiratory therapist are doing together is that they are, they're getting their supplies, they're getting everything that they need to check on the patient safely. They want to make sure that, there's no precautions that they may be missing for this patient. They want to make sure that they're, when they're going and working with the patient, that they are introducing themselves. They're speaking with the patient. They're having some sort of a relationship. They're, making sure that they know in their head before they go in the room what they need to do. And they will, confirm patient ID, using 2 identifiers. They want to do all the basics, explaining to the patient, what they're thinking, and ask the patient if they have any questions, if they have any concerns. And anytime like this patient before, anytime that there's a patient like that is kind of circling the drain and their oxygen levels are dropping, they are going to be, they're going to be concerned, right? They are going to be anxious. They are going to feel like they can't breathe. They are going to tell you that they feel like they're dying. And, sometimes they are, sometimes they aren't. This time she wasn't. But when a respiratory therapist looks at a patient, they do it the same way that a nurse does. It's very systemic. You go through a systematic approach. It's very organized and then we're making sure that we're giving ourselves a time to listen, to think, to pull all pieces together. So not only is it just, okay, this is the handoff I got from the ED and the little snippet that the nurse told me, but I'm going to listen to the lung sounds myself. I'm going to listen to the heart sounds myself. I'm going to do my full assessment. And I'm going to listen to any patient cues. Is the patient telling me something that might be a little bit different than what, maybe the nurse said or the ED physician had said. And then we always want to just make sure that we're assessing those ABCs. We're getting subjective data, objective data, and pulling it together to make sure that we're looking at those, the signs and symptoms of the patient and kind of pulling it together. And I'm pausing on the case study so that we can kind of think about this, that we're all doing basically the same exact thing together, right? We're all doing this assessment of our patients and pulling everything together. And then we're also going to, and then we're going to, figure out how to communicate and how to idealize this patient care. So on top of all those beautiful things that we do together, I just want to point out that the respiratory therapist does a whole heck of a lot more when it comes to lungs and respiratory status and all that good stuff, because they know how to do all of these things under ventilator management that maybe nurses don't know how to do, or could do but probably shouldn't. And then there's a lot of procedures that respiratory therapists can support our patients with and support us with, like chest PT, postural drainage. They can do ABGs and different analyses. They can help with intubations, croup tents for little babies, e-cylinders, non-rebreathers, teeth pieces, all these things that nurses may see but not actually do all the time. And that's kind of a respiratory therapist bread and butter to support our patients, which is why we bring them in early. So
Yeah,
for
and
this
I think
patient, just to
I was going to just say, just to add, is that we have this catalog of patients that we see, so that are all respiratory. So it might be that the nurse may have never seen a patient like this before, but I might have seen 20 patients acting just like this patient. And so that I can pull from my experiences in to see what things we should try first or suggest first for that patient.
Exactly. And that's why we want to communicate and have that together. So, for this patient and in this case study, the respiratory therapist recognized some symptoms in this patient, like the purulent sputum, and noticed some of the symptoms and thought, this patient seems like a real COPDer, and I think they may be a COPDer without actually yet being diagnosed. So they knew that you can treat COPD with corticosteroids, and they recognized an early need for bronchodilators. They suggested antibiotics, and they started the patient on a non-invasive positive pressure after speaking with the team. But they made all those other suggestions for the antibiotics, the corticosteroids, and then the bronchodilators, and the team ordered them because they said, you know what, you're on the right track. You are right. You did the best assessment based on what you're saying, what the nurse is seeing, and what we've seen on chest x-ray, et cetera. We're going to start doing this with the patient, because the RT's expertise on these patients' conditions and needs, along with the RN's expertise, created an optimal care plan for this patient. And I don't know how many of you guys work at training hospitals, but sometimes in June, it's coming up, some of these new interns don't necessarily have that knowledge base. They're very smart and they've got book smarts, but they haven't seen all of this in play. So with this patient, we ended up focusing on a full recovery with this patient. Right, that was our dream come true with this patient. Our optimized outcome was a full recovery, and we did that through RN and RT collaboration. And then when the patient was being discharged, we worked on educating on the warning signs so that she doesn't get into this distress again. And then also preventative care. So making sure she's set up with a pulmonologist and that she's diagnosed and ready, to face her life outside of here. So the characteristics to really support this collaboration are patient-focused, centered focus of care, right? Because that's what we always want to focus on. So we want to have protocols that are for specific patient diagnoses flagged for RT care, when should we automatically call an RT consult. Diagnosis, which emphasizes the RN and RT, communicating prior to a patient going into crisis. Leadership, meaning that having this dual participation. So the nurses and the RTs working together, not only at the bedside, but the nursing leaders and RT leaders working together, and having this supportive leadership in play, so that they know that they can work together and lean on one another, and that it's not going to negatively impact care. It's in fact, it's encouraged. And then ideal communication format. So that's what we're kind of looking at, is, looking at those daily staff huddles. So instead of in the ICU where it's, they can do rounds all together because there's one respiratory therapist, maybe looking at a unit-based respiratory therapist in the for med-surg areas, which is a centralized respiratory therapist, but schedules when they're coming. And then also allowing for an availability for the nurse just to consult the respiratory therapist, so that they can come and help troubleshoot or give input and confirm, assess, etc. But really making sure that the respiratory therapist, whomever that centralized therapist is for that unit, is there when they're rounding and doing those safety huddles on their patient. And really focusing so that the outcome is optimized patient care. So the collaboration between the therapists and the nurses really to impact positively patient outcome. So just really quickly, we idealize this collaboration through discussions during safety huddles at the beginning of the shift, creating specific touch points throughout the day. After their morning, budesonide neb, should we touch base to see how the respiratory rate in O2 is, their lung sounds, maybe she's producing less when she's coughing, having specific warning signs to look for with the staff. Something that an RT might think of earlier than a nurse, and planning those goals of care together. So we're all one team focused on one patient, working with them and knowing the next steps. So especially if we're hitting those, those warning signs, we're optimizing our care. So just no matter how you choose to do it, in what facet, it will enhance any patient's treatment plan. Having better communication with the RTs. Really, their experience in the hospital can set you up for success on so many different levels, and setting the patient up for success upon discharge. And that's the ultimate goal. So I end with this picture here because these are my two littles, and they were staring out. It looks like they're staring out into the ocean, pondering life. But actually, they were really standing there whispering with their bunny ears on, before an Easter egg hunt. And they were planning their plan of attack for that Easter egg hunt at my parents' house, because normally they're the littlest kids, and so they don't get all the good stuff. But they worked together this time, and they came up with their plan of attack and where they were going to go, and they cleaned house. So I was like, huh? And they hear me all the time say better together. And so now that's their little chant. And they say better together, better together. And that's how they end fights. And that's how I think about respiratory therapists and nurses, that we are truly better together. So I know I had to end pretty quickly, and I appreciate you guys coming. And this concludes my presentation. But before we get to your questions, which I see a bunch came in, Lexi's going to tell everyone how to get their CEs.
Thank you, Bridget and Nina, for that very informative presentation. And I will now tell everyone how they can obtain their CEs. This educational activity is approved for 1 contact hour. To obtain CE credits, go to www.saxtesting.com/BO. You will need to register at the site and complete the evaluation. Upon successful completion, you will be able to print your certificate of completion. Support for this educational activity has been provided by Philips. An archive on-demand version will be available on www.betteroutcomes.org. An email will be sent to all registrants when it is available. The on-demand version will be accredited for nurses and respiratory therapists. Now we have time for a few questions and comments from the audience. First of all, ladies, this is for either one of you. In your experiences with the COVID pandemic, do you believe that COVID has brought more RN and RTs together?
Well, I would say undoubtedly yes. I think that I know at our hospital, where Nina and I work, we created teams of respiratory therapists and ICU nurses and floor nurses, so that they could work together, and physical therapists. I mean, that was our proning team, was all working together. And it really created teams in the med surg areas, outside of the ICUs, where we needed that support, especially with second surges, third surges, where they weren't necessarily patients going into the ICU and they were on the med surg floors. The respiratory therapists were really the backbone of that entire response, at least at our hospital. Nina?
Yeah, and I agree. it really put us in the spotlight. So respiratory therapy has has taken kind of a back seat a lot of times, and I think that the pandemic really brought together what we our knowledge base that we have and what we can provide at the bedside, and really working. I've always worked really closely with nurses in the ICUs, and I think the pandemic has brought us closer. And just
Great. Thank you.
it's one of the highlights of that.
I agree,
I
Nina.
agree.
I have another question here. How do you recommend improving teamwork at individual facilities? Like if RNs and RTs don't already work well together, how do you recommend improving that or starting from scratch?
Well, I'm a big believer in interprofessional education. So, I honestly would say that the first step is simulating, and it's kind of forcing teamwork in that you bring people together and you simulate it, and you have various teams working together. So you have those nurses and respiratory therapists working together to learn some certain skills, and then and doing it in simulation, and that will bleed over into real life clinical care. So as opposed as some people are to maybe working with certain staff or there's some sort of stigma, you get them in a simulation room where everyone feels equally uncomfortable. It tends to have people bond together and start working together better. And I've seen a lot of collaboration come out of different teams working together in simulation.
Yeah,
I
I
have a
agree with
question
that
from,
wholeheartedly.
And I also think the other thing, sorry, not to butt in, but I talk a lot, is that scheduling, ensuring that you schedule times. So if you work at an institution where maybe you don't have a large simulation center, so that's not even on the table, but you do have respiratory therapists, you have nurses that don't always work together or see eye to eye, is having the leaders pull together, making this suggestion to your leadership and having them pull together, and create kind of a required check-in. So RTs might not go to your safety huddle, but now they're gonna, and making sure that it's kind of documented somewhere, not necessarily in the medical record, but having some sort of like check. And I know how much people love extra documentation, but just making sure that you have that more for accountability, again, can, forced relationships can kind of create some beautiful collaborative relationships and together.
and we have time for one more quick question here from Pamela. Uh, how do you work through the RT-RN silos to convince staff that they will be better together?
Hmm. I feel like I feel like there are certain people that there's a trouble putting the ego at the door, but I feel like for most clinicians that it's a non-issue with putting egos at the door and doing what's best for the patient. So kind of changing the focus and making sure that we're looking at the patient and their outcome and using everyone for their best expertise. So if there's people that don't you know believe in that. I think that might be more of a managerial issue. But I do really think that, having people understand their strengths and weaknesses is a huge part of that. Um,
Okay, thank you very
Yeah,
much.
I
And
think one of our
now,
mottos is, I was going to say, one of our mottos is remember who you're working for. And it's really you're working for the patient. And if you get ambassadors of two people that collaborate really well together, nurse and respiratory, it spreads. It spreads. Once you start doing it a few times, and people find out that actually it works. Um, it, you can spread it throughout a system.
wonderful. Okay, and now I'm going to turn the presentation back over to Nina for Nikki, I'm sorry, for concluding remarks.
Thank you. And this concludes our webinar for today. I would like to remind the audience there is a survey for you at the conclusion that will pop up immediately, and we would greatly appreciate you sharing your opinions on today's webinar. Thank you again. On behalf of our presenters, Sachs Healthcare Communications, and our sponsor, Philips, I hope you enjoy the rest of your day.